Hi, today we will discuss about nosocomial infection in the pediatric intensive care unit. Nosocomial infections refers to infections that occurred during hospitalization and it was not present at the time of admission or the organism is not incubating at the time of admission. Later on we will see what are the etiological factors, what are the common organisms in hospital acquired infection in the PICU, what are the risk factors of these nosocomial infections, how can we prevent the nosocomial infections, and finally the antibiotic protocol for nosocomial infection in the pediatric ICU setup. So let's begin. First of all, see the definition. So simply the definition of nosocomial infection is it refers to infections acquired during hospitalization, okay, and that was not present at the time of admission, and that was not present at the time of admission or not incubating. So what are the major sites of nosocomial infections? Major sites of nosocomial infection. See, there are various in the body, various organs may be infected, but the most common in the pediatric ICU setup are: number one, bloodstream infection. Then your pneumonia, which also include the ventilator associated pneumonia, which is very important to know, and urinary tract infection. Okay, these sites vary according to age of the children. In a 5 years old child, bloodstream infections are more common, then comes pneumonia and then UTI. And for a 5 to 12 years old child, pneumonia is more common than bloodstream infection and then UTI. And for a more than 12-year-old adolescents, bloodstream infections are more common than UTI than pneumonia. So this is the thing important to know. Next, come to the etiology and risk factors of these nosocomial infections. First of all, let's see bloodstream infections. The common etiological factors in a bloodstream infections are Acinetobacter, then Klebsiella, then Staphylococcus aureus, coagulase negative Staphylococcus, and Enterococcus. So these are the common organisms which we encounter in the bloodstream infections. So this data is from AIMS in 2018. So this is the AIMS data, and this may vary according to your hospital setup. So in every hospital there should be a surveillance system. They should time to time evaluate what are the common organisms that are present in their hospital setup. So what are the risk factors of these bloodstream infections? The risk factors of bloodstream infections are total parenteral nutrition. Okay, then your blood transfusion, then your catheter hub colonization. So infection related to the central venous catheter. If you do a continuous manipulation of the lines, that can also lead to this bloodstream infection. And next we will see what are the common etiological agent in ventilator associated pneumonia and what are the risk factor of ventilator associated pneumonia. So in ventilator associated pneumonia, most commonly isolated organisms are Acyanobacter, Pseudomonas, Klebsiella and E. coli. Now let's see some risk factors. One is reintubation. Some genetic syndromes sometimes may predispose to ventilator associated pneumonia. Immunodeficiency and immunosuppression may lead to ventilator associated pneumonia. Now we will see what are the common etiological agents in UTI and what are the risk factors. Klebsiella is a very common etiological agent, and then Enterococcus. And fungal organisms are also very common in case of urinary tract infections like Candida tropicalis, Candida albicans, etc. And some risk factors of UTI are: 1. Bladder catheterization. 2. Prior antibiotic therapy. Now we will discuss strategies for decreasing healthcare associated infection in the pediatric ICU. So number 1, CLABSI bundle. So what is CLABSI bundle? Central line associated bloodstream infection bundle. So we basically, our idea is to prevent central line associated infection. If we can prevent that, so lots of bloodstream infections can be prevented. The components of CLABSI bundle are aseptic insertion technique, second, skin preparation with chlorhexidine, skin preparation. You have to use sterile gloves. Use sterile gloves. And before access, you should always do the cleaning of the hub. Similarly, we can prevent ventilator associated pneumonia also. VAP bundle. So what are the components of VAP bundle? Number 1, elevation of head between 30 degree. Daily sedation holiday. Daily sedation holiday. We should always try to give this sedation holiday. We should always check whether what is the condition of the child, whether we can extubate. Oral hygiene. We should maintain a good oral hygiene. So basically, what happened? Elevation of the head between 30 degree, daily sedation holiday, and oral hygiene. These 3 things are very important. Similarly, we can prevent UTI. We should limit duration of catheterization. We should use aseptic technique. at insertion, and we should maintain a closed drainage system. Okay, before going to the protocols, let us see some of the treatment recommendations. Gram-negative bacteria are the most important organisms for healthcare-associated infections, and Acinetobacter, Pseudomonas, and Klebsiella constitute about 75% of the isolates. Remember. So the recommended empirical antibiotics that would cover common pathogens are piperacillin and tazobactam, and cefoperazone and salvectam. Okay, and the specific choice of antibiotic is guided by unit antibiogram and the surveillance system of your healthcare facility. So it may vary from place to place. Now we will come to the antibiotic protocol. When the child is admitted in the PICU, there may be any indications. It may be a case of diarrhea, it may be some CNS case like some meningitis, or there may be some kidney problem like renal failure, or there may be ascites. So when you suspect a nosocomial infections, okay, from the clinical features like fever, breathing difficulty, or anything you are suspecting that there is a nosocomial infection, so what is your approach? What should be your approach? First of all, when you suspect hospital-acquired infection, straightforward, you should go for investigation. You should go for a blood culture sensitivity, blood RE. You can go for a bronchoalveolar lavage microscopy or culture sensitivity, and you can do a urine RE culture sensitivity and fungal culture, very important, fungal culture. So once you have done this, so what will happen? You will have an idea whether it is a bloodstream associated infection or pneumonia, or it is a UTI. So with these investigations you can get an idea. So if the clinical features and the investigations suggest bloodstream infection or ventilator associated pneumonia, then you should look for the blood parameters. If the child is having thrombocytopenia or there is derangement in the liver function, okay, so if there is thrombocytopenia or liver function is deranged, okay, that means the child is sick. So in that case you should start piperacillin tazobactam 300 mg per kg per day thrice daily, TDS, and amikacin 15 mg per kg per day once daily. So if there is thrombocytopenia and there is problem with the liver functions, then you go for piperacillin tazobactam and amikacin. So piperacillin tazobactam and amikacin. And if you find here that there is platelet is normal, LFT is normal, then you can start cefoperazone salvectam. What is the dose? 40 to 80 mg per kg per day. So it can be given TDS or twice daily. So it is given 8 to 12 hourly. Okay, but remember, this does not cross blood-brain barrier. And the second drug you will give is amikacin 15 mg per kg per day, single dose. After doing this, you should observe for 48 hours. In 48 hours, if the response is good, then you should continue with this same antibiotics. But if after 48 hours there is no improvement, there is deterioration of the hemodynamic status, or you are getting evidence of gram-positive organisms, then you should start vancomycin. 48 hours, hemodynamic worsening occur or gram-positive organism in culture sensitivity, then we have to add vancomycin. So what is the dose of vancomycin? The dose of vancomycin is 40 to 60 mg per kg per day QID. Understood? Now after giving vancomycin and the other antibiotics, if the child is still worsening, then you have to go for second line drugs. Okay, if not improving, then you have to think of second line agents. So what are the second line agents? Very important. You can give imipenem, or we can give meropenem. So imipenem is a broad spectrum beta-lactam antibiotic which acts against aerobic and anaerobic organisms and gram-negative organisms. On the other hand, meropenem is a very good extended spectrum beta-lactam antibiotic. So imipenem, the dose is 60 to 100 mg per kg per day QID, and the dose of meropenem is 60 to 120 mg per kg per day TDS. Okay, if 120 is for CNS infection, otherwise you go for 60 mg per kg per day, that means 20 mg per kg per dose TDS. And sometimes you can consider another antibiotic, and that's your colistin. Okay, sometimes you can consider colistin. So what is the dose of colistin? 50,000 unit per kg per day. You have to give TDS. Okay, so 50,000 unit per kg per day. 50,000 unit per kg per day, and each vial contains 10 lakh unit per vial. You have to mix with NS, so you can go for colistin. So when you suspect a nosocomial infection or a hospital acquired infection in the PICU, and after the initial assessment and the initial investigation, if you find findings suggestive of UTI, then what will you do? So if you find findings suggestive of UTI, so what you can do, you can go for a third generation cephalosporin. Okay, so maybe ceftriaxone, you can go for a ceftriaxone plus amikacin. Okay, so if you give this and there is no improvement, there is worsening, then you should go for piperacillin plus tazobactam or cefoperazone sulbactam. So let's just revise it again. So let's revise the antibiotic protocol. So if when you suspect a hospital acquired infection, you go for a bronchoalveolar lavage, blood CS, urine CS, and fungal culture. If your findings are suggestive of UTI, Then you go for a third generation cephalosporin and amikacin. If there is worsening, as a second line, you can go for piperacillin tazobactam or cefoperazone sulbactam. But if you are finding it suggestive of bloodstream infection or pneumonia, then you look for the other condition of the child. If there is thrombocytopenia and derangement in the liver function test, you should go for piperacillin tazobactam 300 mg per kg per day, twice daily, or along with that you have to give amikacin 15 mg per kg per day, once daily. And you assess after 48 hours. In 48 hours, if there is hemodynamic worsening and there is gram positive in the culture sensitivity, you should add vancomycin. So vancomycin, the dose is 40 to 60 mg per kg per day QID. And still there is worsening, then you can go for second line antibiotics, which is imipenem and meropenem, or you can go for colistin. Thank you so much.